Temporoparietal facial flap is a thin, highly vascular, pliable facial flap which can be harvested from the temporal region. This flap can be used in reconstruction of head and neck, orbit, ear like microcia repair, oral cavity and skull base defect repair. So this is highly vascular flap which can be used reconstruction in the head and neck area. You can see this flap very thin, highly vascular that can be elevated from the temporal region to reconstruct any defect in orbit, ear or head and neck region. Surgical anatomy of this flap. Layers of temporal region from superficial to deep. Skin, subcutaneous tissue, temporoparietal fascia, loose areolar tissue and the temporalis muscle. So you have to elevate this flap between the subcutaneous tissue and the loose areolar tissue, or you can say over the temporalis muscle. This flap is a continuation of SMAS, superficial musculoaponeurotic system. It lies superficial to deep temporal fascia and it is very thin, pliable and vascular flap. Vascular supply of this flap coming from superficial temporal artery, a terminal branch of the external carotid artery, which travels just anterior to the ear, anterior to the tragus. It divides into frontal and parietal branches and it's having same name vein like superficial temporal vein. Nerve related to this is the temporal branch of facial nerve which runs in the same plane with the superficial temporal artery, and auriculotemporal nerve which lies near to the superficial temporal artery. So these two nerves are very close relationship with the superficial temporal artery. So we have to take care of these nerves. Indications are auricular reconstruction like microcia repair, covering cartilage grafts, oral cavity defect like palatal defect or buccal cavity defect, orbital and periorbital reconstruction, skull base defect like CSF rhinorrhea or CSF leak repair, parotidectomy defects, and laryngotracheal reconstruction. In this, we have to use free flap. The characteristics of this flap, it is very thin, ideal for delicate reconstruction. It is highly vascular, having low risk of necrosis, very flexible and pliable, can be harvested with pedicle or free flap. It is hairless if taken posteriorly. Now surgical technique. Doppler to identify superficial temporal artery, mark course of the artery and flap design. Incision is made anterior to the ear over the STA course. Skin flap elevated carefully to expose temporoparietal fascia. Flap dissection in subdermal plane preserving the STA branches. And flap can be rotated, tunnel or detached depending on the need and recipient site. This flap can be harvested up to 10 to 14 cm in length, 6 to 8 cm in width. Can be rotated in the midface, oral cavity and scalp. Complications of this flap are alopecia, facial nerve injury, hematoma, scarring and flap necrosis. Advantage of this flap, it is excellent vascularity, minimum donor site morbidity, versatile in head and neck region, can be harvested with the skin, can be used as composite flap. Limitation of this flap are limited volume, only soft tissue is there, not suitable for large three-dimensional defect, or sometime you have to do hair removal for composite flap. Case example of this flap are microcia repair, intraoral defect, post-tumor excision, orbital floor reconstruction. On conclusion, the temporoparietal facial flap is a workhorse flap for head and neck reconstruction. It offers reliable vascularity and excellent versatility to covering the complex defect. Understanding the surgical anatomy and meticulous technique is key important for the ENT surgeons.